Getting started, which is great. Thank you very much indeed. So, and I will now go to the lobby and start admitting people. It's 10:29. Well, I suppose I could be really, really good and wait till 10:30, but
no, just open it, Steve.
oh, come on. All right.
Well, enthusiasts.
Late.
All right. I'm
Champing at the bit.
admitting. I'm admitting. I'm admitting. Yeah. Good morning. Good morning, Amanda. Good morning, Aaron. Good morning, Gemma. Good morning, Stuart. Good morning, JQ. Good morning, Matthew. Good morning, Carey. There's if you've just joined, if you could go on mute, that would be great. There's a bit of background noise at the moment. Morning, Adam. I'll monitor. Yeah, if you have just joined, if you could mute, that would be great. Just to cut out any background noise.
Good to see you. Thanks so much for the session you did for us. Evan Guppy of the PPF.
Oh, yes, indeed. Hi, Evan. Yeah, thanks very much for joining.
Morning, Evan.
Good morning, Charles. Morning, Con.
Morning,
Good morning, Ian.
Morning, David.
Got David. Got Peter as well.
Yeah.
So we'll leave it another minute or two. Morning,
Wilson.
Wilson.
We haven't mentioned your name. It's not because we don't think you're important. It's just we haven't found you yet.
We haven't mentioned Kate and we haven't mentioned Bob. So morning, Kate and Bob. Hope we are well. If you've just joined, if you could go on mute, that would be brilliant. Charles, I'm going to mute you if that's all right, just to cut out any background noise and allow Stuart to present. Okay, so that's all good. And a few others joining. Good morning, Ant. Good morning, Paul. If you could just mute if you just joined, that would be brilliant, just to cut out some background noise. So Mohsin, if you could mute, that'd be great. Thank you. And we're nearly there, I think. So Stuart's fine, Henry's fine, and everybody else is muted, which is good. Okay, so I'll monitor the lobby. So right, we will now make a start. Good morning, everybody. Welcome. Turn that off. Welcome to Pension Playpen, our weekly coffee morning sessions. I'm Steve Goddard, CEO, and we have on today Stuart McDonald, MBE, who's head of longevity and demographic insights at LCP, and our host for the day will be Henry Tapper, who loves talking about this particular subject. And perhaps Henry, you'll tell us why later. Thanks everyone for attending. This session is being recorded, so if everybody's happy with that, big thumbs up. Con and Ant and Evan and everybody, we're being recorded. And at this point, if you'd like to ask a question during the session, Stuart's happy to take questions as and when, so raise a hand. We will also open the chat up, so if you want to put any comments or chat in there, please put that in there as well. And we do like people to ask questions and spark debate. So without any further ado, I will monitor the lobby and pass on to Henry. Henry, over to you.
Okay, and over to you, Stuart, because I've got nothing further to say. Thanks for that, Andrew.
Great. Oh, that was short and sweet. So good morning, everybody. Thank you for joining me on Valentine's Day. I was going to look for a sort of heart image, but I ended up going for something somewhat more medical to throw on the first slide. You know, it is. We're going to talk a lot about the heart today. So unfortunately, COVID is more than a simple respiratory infection, and unfortunately, you know, that cardiovascular health is a big part of the story that I think we're experiencing today and likely to experience in the future. So trust me to put a downer on Valentine's Day. So. For those that don't know me, then yeah, I'm Stuart McDonald. I'm a partner at LCP. I also have a role at the CMI. I'm on the executive committee there, and I'll be taking over as deputy chair in 2 weeks' time, and then 3 years later, unless something goes wrong, taking over as chair of the CMI. And at the start of the pandemic, I set up the Actuaries Response Group, so a way by which the members of the actuarial profession that wanted to contribute in some way to the response to COVID, initially informally, but we later ended up, some of us having more formal roles, could kind of get involved and make our voices heard. So we felt, and I think it was vindicated, that there was a role for actuaries in sort of analysing the emerging data and trying to make sense of it. So in terms of some of what we'll talk about today, as Steve said, feel free to pop your hand up if you want to ask questions as you go. If you can, try not to ask something that's coming later. Broadly, what we'll talk about is life expectancy, a little bit of scene setting, just to make sure we're all on the same page about what that means, what historic progress we've seen, and where we are today. Because it's the UK and because it's an unavoidable part of understanding the COVID story and life expectancy more generally, we'll talk about a little bit about inequalities of life and health. I'll then explain what we've seen in respect of excess deaths and why, perhaps surprisingly, actuaries didn't do all that much about the awful excess deaths that were experienced in 2020 and 2021, but are now starting to respond and express a view that there may be adverse consequences to life expectancy based on what we're seeing in 2022. So yeah, we'll talk a bit about what comes next, and I'll talk briefly about the next version of the CMI model. So that's coming out in June. For those that are more interested in that, I'll mention it again later. The CMI are holding a webinar on that next week. We're also here at LCP holding a webinar on that. We'll talk a little bit in more detail about some of the things that I'll cover today. So let's start with life expectancy. So it's a badly named summary statistic. It doesn't really tell you very much about how long somebody alive today is going to live, but it is a very informative picture of what has been happening in terms of death rates, and it's great in terms of doing things like this. I love this chart, really powerful, an awful lot of information packed into one chart. We could spend an hour on this, but I promise I won't. In brief, some of the things that you're seeing here, you're seeing the progress of life expectancy over time. There's also what we call convergence. So you can see that actually much of the progress in life expectancy, particularly early on, and because this chart's going back to the 1700s, particularly from kind of 1850 to kind of 1950, a lot of the progress in life expectancy was about addressing life expectancy of children, infants, and young adults. So you can see much greater progress in the red and orange lines at the bottom, converging up towards the higher lines. Where it gets more interesting, though, is that more recent progress over the last kind of sort of 70 years or so has been experienced across the age range. So you can see progress even amongst the eldest. But more, more muted progress and more recent progress. But it is quite interesting just to think that, going back 50, 100, 200 years, actually, if somebody had already made it to 60, 70, as you can see from these charts, their life expectancy wasn't so different from what it is today. The other thing that's really relevant that I draw out on this chart is the Spanish flu, which hopefully most of you can see around 1918-19. And of course, the World War was happening around the same time, World War I, so that's also partly in there. But a lot of this is flu mortality. You can see how sharply life expectancy fell, but how quickly it bounced back. And that is because this is showing you period life expectancy. So this chart is not showing you actuaries' opinions on what will happen in the future. It's just an examination of current death rates, and hence when death rates go up, like period life expectancy comes down. Quite interesting to contrast this with what we've seen so far in respect of COVID. Also worth just thinking about how much worse COVID could have been. You can see from this period life expectancy chart that it's children and young adults that saw the biggest falls in life expectancy in respect of Spanish flu. There was much less of an impact at the older ages, where people had some historical immunity to that flu strain, it's believed. COVID very much the reverse, with a lot of impact at older ages, but mercifully younger people much less seriously affected. Let's look then at what's driven those changes in life expectancy historically, because again, it's kind of relevant for where we've got to and our ability to eke out further progress in the future. So you can see these incredible falls in circulatory disease, cardiovascular mortality. So that has really driven a large part of the progress in life expectancy over the last 50 years. This is showing you males age 65. You get a fairly similar picture if you look at a broader age range. You get a fairly similar picture if you look at females. Bit more of an increase actually for females in dementia and Alzheimer's. You can see there that that's one of the causes of death that's that has been increasing. There's some messy stuff going on with respiratory diseases around how flu was coded, but generally it's a downward trend there. A slight downward trend with cancer, but you can see how much slower progress has been there compared to cardiovascular. It is cardiovascular where we've made really, really big progress on so many different fronts: prevention, treatment, and even cardiovascular deaths can be very sudden. So even things like telecommunications have played a role. So not having to run to a phone box and call an ambulance, people carrying mobile phones with them. Strokes and heart attacks, it's all about the first 15 minutes. And we'll come back to that because that's really relevant in terms of recent conversations about ambulance response times. But the ability to get to somebody quickly after a cardiovascular event is really important. So I guess that the thing that's worth thinking about is that even if we could somehow replicate that incredible progress in cardiovascular, because it is no longer by far and away the largest cause of death, even if you could repeat that sort of 80% fall in cardiovascular, you'd only be going from 1 to 0.2. You wouldn't be going from 5 to 1. So it wouldn't have such a big impact on deaths as a whole. If we want to make progress now, we do need to increasingly start to make progress with cardiovascular, with cancers, with dementias, and the things that have been harder to address historically. And the last point I'd point out for the very observant is on that orange line in the other causes of death, the sudden vertical jump in 2020. It won't take much to realize that is COVID. So let's then move from causes to inequalities as part of our kind of general scene setting. So there are huge differences in life expectancy across the UK. This chart on the left is from one of my LCP colleagues, Johnny Pearson Studdart, and this is showing you a 27-year gap in life expectancy between the small local areas with the highest and lowest life expectancy in the UK. And as you can see from the chart and the bits that we've zoomed in, there are regional differences, north-south divides and, rural, urban and so on. But there's also hyper-local differences, differences between neighbourhoods and so on. You'll have all read stories about how you can travel 5 minutes on the tube and life expectancy increases by a decade. It really is a huge part of the story here in the UK, because a measure like life expectancy is driven as much by the very early deaths as by what goes on in the average. So if somebody dies very, very young, that's going to disproportionately skew down the calculation. The other thing that's worth pointing out is that things have been going backwards for the poorest. So on the chart on the right is showing you progress. It's showing you the sort of differences in males and female life expectancy, and the poorest are the ones on the left. And you can see that female life expectancy, it fell for the poorest 10%. Whereas for the richest for all males and for the richest 90% of females, over that 6-year period, there was progress. So this is pre-pandemic stuff, but we had essentially widening inequalities of health and life expectancy in the UK. So really important for pension schemes to think about where the individual members of schemes are located. You know, where do they live? Who are they? So that you can understand the extent to which the kind of macro population level trends apply to individual schemes. I'll pause there in case there's any kind of urgent questions on life expectancy or inequalities before we come on to what's happened over the last couple of years.
I had one question, Stuart, which was when you showed us that spike in excess deaths from other, was that the impact of COVID, or was that COVID itself? By which I mean, was that the pure impact of COVID, or was it the knock-on effects of COVID causing excess deaths in other areas?
That will be predominantly the pure impact of COVID. So if we think about COVID deaths over 2020, 21 and 22, so this chart's only going up to 2020 really, almost all the excess deaths, in fact, actually more than all the excess deaths officially, were COVID in 2020. So but yeah, essentially pretty much all the excess deaths we saw in 2020 were directly from COVID. Same story really applies to 2021. It's only as we've gone through the pandemic, as I'll come on to, that we've started to see more in the way of kind of indirect impacts. There are and there will continue to be, spoiler alert, a lot of indirect impacts and additional deaths arising from COVID, but not directly. But yeah, this 2020 is purely the direct ones, largely because of the fact it's categorized. So, you know, if this was additional people having strokes, then it would show up in the green line instead of the orange line.
Okay.
Stuart, one other question, sorry, from me. The only other line that sort of seems to be trending upwards is dementia and Alzheimer's.
Yeah.
Is there any medical sort of research as to suggest what's the difference between the 70s and the 20s, 2020, 2010s going up and up and up? I mean, it's, you know, on this slide, it doesn't look huge, but it's an upward trend. Is there any medical evidence on why is dementia and Alzheimer's on the rise?
Yeah, well, I mean, there's various things going on. You know, one thing that you're always dealing with when you're dealing with breaking mortality down into individual causes is the idea of kind of competing causes. So if moving away from age standardized analysis for a moment and thinking about numbers, the fewer people die at 50 from a heart attack, the more people there are to die of cancer at 70. And the more progress you make in dealing with cancers at age 70, the more people you have to die of Alzheimer's and dementia in their 80s and 90s. So there's a little bit about competing causes of death playing into this. Yeah, beyond that, there are, you know, there's going to be some stuff around classification. So there's less stigma amongst the medical community in explicitly classifying deaths as due to dementia and Alzheimer's than there was sort of 20, 30 years ago. It's, you know, as it becomes more common as a society, as we have more and more older people, and it happens to more and more families, GPs are much less circumspect in terms of how they, you know, what they put on a death certificate in respect of cause.
Okay, thank you.
So both of those playing in. Unless there's any more, let's move on to the last couple of years. So I'll walk through these fairly quickly and just layer this up. Hopefully some of you have seen a lot of this. The red line is showing you 5-year average deaths. So this is using ONS death counts numbers, and we can maybe talk a bit later about different ways of looking at this, but this is the most immediately available data. This is using death registrations because that becomes available much sooner in the UK. A lot of our work here is done. The downside to using death registrations data is it gets a bit distorted by things like bank holidays. You know, you have a bank holiday, you've only got 4 working days instead of 5, you get a 20% fall in the death count, and then some catch up the following week. You can see from the start of 2020 that deaths were reasonably low. They were actually pretty similar to 2019 in that regard. You can see how brutal that first wave was. Suffice to say, when we went into 2020, I mean, I've been monitoring excess deaths for goodness knows how long. I was looking back at some comments I was making back in 2018 when we had our bad flu season recently. I had to extend out the x-axis, the y-axis on this chart because it didn't go up above 20,000 before. I think it went up to about sort of 17,000 on the chart. So really brutal and unprecedented impact that first wave had. And then you can see that death counts fell once we got past that first wave. Everybody was locked down. COVID was falling away, and a lot of our more frail individuals had sadly died early, so there were sort of fewer of them around. The next slide takes us into 2021. So you can see that we had this really again, more pronounced, a more extended period, a less sharp spike, the second wave, and that played out at the start of 2021. But again, once that wave was over, death counts went back below normal levels and stayed there really until the second half of 2021, when a few things happened. We unlocked. We got the Delta variant came along, and then once we got to the very end of 2021 and into 2022, we had the next evolution, the Omicron wave. So 2022 shows us Omicron era, and it's really quite interesting. First thing I would point out is that over on the left, the winter period, deaths below what you would normally expect. That's despite the BA1 Omicron wave hitting us. So what was going on there? Well, Omicron's pretty bad, but actually in terms of the impact that a wave had, it wasn't as bad as an average flu season. So I mean, don't take me the wrong way. You don't normally get 5 flu seasons in a year. But looking at an individual wave in isolation, that first wave in the sort of traditional flu season timing was no worse than a normal flu. So what we've got through 2022, and it's a bit messy because of the bank holidays, but hopefully you can see, you could almost draw a straight line through. Deaths in the UK are normally very, very seasonal, as you can see from the sort of red line, the average pattern. We didn't have that normal seasonality. They were below normal in the winter, and then they were above normal once we got into spring, autumn, and spring, summer, and beyond. And in particular, they were consistently higher week on week from about April, May, as you can see from that dark blue line. And that's what really is causing a lot of concern, because you've got a number of well, we'll come on to what's driving it, but unlike those short, sharp shocks that we saw in the first and second wave, it's a sort of consistent chronic problem, week after week. Not newsworthy in quite the same way. Deaths 10% higher than normal again. But actually, if you look at the cumulative effect, it's a comparable loss of life, similar area under the curve, if you like, to what we saw in those early waves. How has 2023 started? Well, pretty shocking at the start, up there with the second wave in terms of impact, but actually much better. So it's back. You can see last week's data was back at the same level as the 5-year average, and the ONS published another update this morning, and again it's basically in line with the 5-year average. I mean, that's not all that great. As I said earlier, after you've had a shock of very high deaths, as we just saw, you would hope things would go below average for a bit. But at the very least, whatever was driving the acute spike that we saw in deaths reported in early January seems to now be behind us. So how does this look when we move away from counts and into a sort of age standardized worldview? Now, this chart's relatively complicated. What we're doing is we're comparing individual years, standardized mortality. So by age standardized mortality, what I'm doing is I'm allowing for the aging population and the growth in the population. So we've got more old people, so you expect more deaths each year. So we're controlling for that. I won't spend too long on this chart, but basically you can see that the black line, hopefully it's clear enough, on the left-hand side, the first few weeks of the year is kind of consistent with some of our worst years of the last decade. So similar to 2015 and 2018, both of which we had really bad flu seasons at the start of the year. But not as bad as 2021, which was rather more extreme as a result of that that second wave. So let's move past this and start to look at the sort of quarterly view, excess deaths overall. So this is now just breaking it down. It's using the CMI's age standardized analysis, which is kind of the gold standard for how you would examine this. And it's basically comparing age standardized excess deaths with 2029, which we're taking as a sort of pre-pandemic reference year where mortality was pretty good. It was, but it wasn't unattainably good. It was similar in 2029 to the first quarter of 2020 and indeed to the last 9 months of 2018. So we had this kind of 2-year period of very low mortality. What does the excess deaths show? Obviously, very, very large spike in the second quarter of 2020 when that first COVID wave hit us. Then deaths slightly below normal, as you can see in the third quarter, building again in Q4 of 2020 and Q1 of 2021. And then again, after that spike at the start of 2021, deaths falling below the level we'd expect. And then, as we move, it picked up, as you can see, in the third and fourth quarter. So as we opened up, as Delta sort of started to hit us. But then this building problem through 2022. So deaths below the normal level in the first quarter and an increasing amount with around 10,000 deaths in each quarter. In the second half of 2022, so around 20,000, in excess of 20,000 for the UK as a whole in the second half of 2022. And I haven't got 2023 on that chart, but you can see at the top that in the first 3 weeks, first 4 weeks of 2023, there's been over 14,000 excess deaths occur. It is worth being conscious, though, that some of this is about timing. So the flu season hit us earlier than normal. Normally, flu would arrive in January, and the deaths might get recorded late January, early February. This time it hit us around Christmas, and so we've got this big wave of deaths recorded in the first couple of weeks. So I am hopeful that we will see some reversion, that we won't see this 2023 excess deaths number continue to rise so abruptly. Were there any kind of urgent questions before I move on?
There's one question from Andre, which is, I think you've answered, which is, are the dips for 2022 due to bank holidays? Could you just confirm?
Yes, absolutely right. Those kind of little V shapes, that's just bank holidays. You get a dip and then a catch up after. And
a second question from Charles saying, are the drops in the first quarter a reflection of reporting after the Christmas break?
Yeah, similar. You do get a there's an apparent discontinuity on this chart. If you have a look, you always get this fall towards the end of the year, lower deaths recorded over the Christmas week, and then some catch up at the start. The first week has a bank holiday in it, New Year's Day, so it's usually the second week of the year that is the worst. Fortunately behind us now.
Great, let's carry on then.
Great. This is now looking at age standardized mortality rate against a CMI 10-year average. Now, this isn't a this is something the CMI do for historical reasons. It's not suggesting for a moment that a 10-year average mortality rate is the right way to look at it, but this is from one of the reports. So the CMI has been great in terms of the way it's positioned a lot of its reporting at the general public through the pandemic. But actually, this is for one of the reports aimed at actuaries, and it's just basically to say, how does the current year compare to historic? And essentially, if you're comparing to a 10-year average that includes the peak pandemic period, we would expect every age group in 2022 to have significantly lower death rates, as indeed we see for the oldest group, the sort of 75 to 84 group that's shown here. But really interestingly, for the younger adults, death rates are a lot higher than they ought to be. So you can see here for this 20 to 44 age group, death rates about 3% above what you'd expect for males and about 6% above what you'd expect for females. And then that effect sort of dropping away as you move up the age ranges. I should say that the age ranges, the older ages, are much more likely to benefit, if you can think of it that way, from mortality displacement. So a lot of the older, frailer population died during the sort of peak pandemic years. So there's fewer of them about, and the ones that are about are generally not in such poor health. But yeah, really interesting and quite concerning to see such significantly higher age standardized mortality rates amongst younger adults. Let's stop teasing with numbers and start to get into causes. Now, there's only so far that I can go as an actuary in terms of examination of causes, but I could talk about where the data is pointing and what I think is going on. So firstly, let's just break it down between COVID and other. These charts are essentially from the CMI, and long story short, as I mentioned earlier, in 2020-21, basically all the excess we were seeing was COVID. There is a significant, what we'll call non-COVID excess going on as we move into 2022. So by non-COVID, I'm not taking a view personally. I'm just looking at what doctors are saying on death certificates. They're either attributing COVID as playing a role in the death or they're not. What we're doing essentially is just deduct the COVID deaths from the excess and call what's left, whether it's above or below zero, your sort of non-COVID. So you can see COVID's been fairly flat, fairly consistent, usually between 0 and 1,000 excess deaths, always positive because you can't, there's no COVID in the average. Whereas the non-COVID numbers jumped around a bit, but actually, as we got towards the end of 2022, it's been very significant, a really quite elevated number of deaths. Let's look at some different causes then. So this is from the Office for Health Improvement and Disparities, so OHID. It's part of the Department of Health and Social Care, and they've got some great reports, and you can look at deaths by age group, by place, by cause, and so on and so forth. I've called out two contrasting causes of death here, both major killers. One of them is cardiovascular, and the other is cancer. Just so you understand what's going on with these charts. When on a death certificate, you can say that a cause was the underlying cause, or you can say that it contributed. We've heard a lot about that with COVID. Did they die with COVID or of COVID? So the dark grey bars are where somebody died of that cause. So the dark grey bar at the top is people who died of cardiovascular conditions. Then the light grey are the additional ones where it was mentioned on the death certificate but wasn't felt to be the underlying cause. And then the amber orangey ones are your COVID deaths. So you can see for cardiovascular in the last year or so, deaths significantly above what would be expected and above by a greater extent than can be explained by COVID. So there are non-COVID cardiovascular deaths occurring. But you can see for cancer, generally death rates about where we would expect in the main. Where they are higher, typically looks like it's somebody that died with COVID and cancer, but no real signal coming through there just yet. Which is not to say that it won't in the future. As we start to think about what's driving the excess, you'll see how that can play out for different causes and conditions over different time periods. So drivers, what's going on? So we've talked a bit about sort of chronic excess that we saw all the way through the last 9 months of 2022. And then, as I highlighted, there was a really short, sharp, acute spike that took place around kind of building up into December and extending into January. So things to think about when you're considering the excess. Firstly, if you're working with death counts like the ONS weeklies, then you need to be aware of the aging population. It sounds like a sort of technical actuarial point, but it's really, really significant. If you're looking back 5 years, the number of over 75s will have increased really quite markedly during that time. And it just means you expect deaths to go up by about 1.5% every year. So if you're comparing 2023 to 2019, that's 4 years, 6%. That's a newsworthy excess there. So it is important to adjust for it. Demand pressures on the healthcare system. So we've heard a lot about it in the press. Quite right. I'll work through momentarily some examples of how badly that can impact excess deaths. But we can see ambulance waiting times for category 2 emergencies. I've said they're greater than an hour. In fact, they were greater than an hour and a half in December. So this is your heart attacks, this is your strokes. You'll remember earlier on that I said what a big difference it made having a mobile phone, because it meant more people were able to get an ambulance out to them within the first 15 minutes. We're not even getting an ambulance out to people having heart attacks and strokes in an hour, where they are classed as category 2 for much of the last 4 months of 2022, so September onwards, outside targets, and particularly bad in December. Fortunately, it's improved a lot as we've gone into January. Really long waiting times in A&E. Again, over 700,000 people in December waiting over 4 hours in A&E. That's huge numbers. Direct deaths from COVID. So that's been a factor through 2022. As I say, we had 5 waves of Omicron. But it was also a factor in December. So the 5th wave peaked around Christmas. More significantly, though, we also had that flu, which also peaked around Christmas. A really, really early, really, really sharp flu spike this year, possibly related to lower levels of background immunity, the fact that not many of us have had flu for the last few years. Leading to some greater susceptibility. So we're not the only country where it came roaring in very, very quickly and spread very, very quickly, and then unfortunately went away very, very quickly as well. Summer heat waves, they have a short-term impact on excess deaths, so you can see them in the weekly spikes. They have less of a long-term impact, I think. They probably just accelerate deaths by a few weeks. But the cold winter will really make a difference, particularly given the cost of living crisis that we've got going on, and the difficult choices that people are making between heating and eating. I talked earlier about the seasonality that we see in UK excess deaths. In the pre-central heating days, the seasonality was more pronounced. It had fallen, and we'd found ourselves into a less seasonal pattern over the last few decades. But that seems to have been turning around over the last, not just the pandemic period, actually. We were seeing an increase in seasonality for the last few years, with sort of spikes in 2013, 2015, 2018. Yeah, something definitely going on there. Missed and delayed diagnosis, I'll talk about momentarily. But we have seen big falls in prescriptions. I've mentioned blood pressure on this slide, but others too. Cardiovascular risks. Lots going on. You can see a lot of the excess is in cardiovascular. It does appear from a good number now of published studies that COVID carries a tail of elevated cardiovascular risk. That's not uncommon, and we've seen that after particularly severe flus in the past. It's normal for a lot of the extra deaths that occur during flu season not to be from flu, but to be from heart attacks and strokes and so on. And of course, all these factors interact. The hardest question you can ask me is to put numbers to different factors. If we have an extra heart attack arising where somebody's had COVID recently and they should have been on blood pressure medication, but they didn't get diagnosed earlier on in the pandemic, and then they don't get to the hospital in time because of ambulance delays, which one do you pin that on? We've got a bit of a perfect storm of competing causes that are all contributing, and as I've drawn out, as we've walked through these, some of these were very short-term factors, in particular the real demand pressures on the NHS related to that flu spike that we saw in December. Was something that made things very, very bad for a short period and is hopefully now behind us, whereas some of the other factors are more chronic in nature. Let's look a bit more in detail at the impact that demand pressures can have on the NHS. So this was a little bit of work that my team did around Christmas, initially working with the Independent, but it went much wider, particularly when Royal College of Emergency Medicine came out with some very, very similar numbers. So this is the 300 to 500 deaths being explained by A&E delays that made most of the front pages. Essentially, this comes from published research that shows a strong association between delays in A&E departments and 30-day mortality. I want to be clear, this is 30-day mortality. It's not people dying in A&E. It's not necessarily even people dying in hospital. It's people, it's just an observational association that shows that where you get a lot of extra people waiting a long time to be admitted, they get worse outcomes, essentially. And over that coming month, you see excess mortality. The approach is actually pretty simple. For every 82 patients waiting 6 to 8 hours, you're going to see an extra death. For every 72 patients waiting 8 to 12 hours, you're going to see an extra death. We don't actually know once you go above 12 hours what the number is. I've used 72. I've basically, which I think is a cautious estimate. So I've basically said that let's assume things get no worse if you're waiting more than 12 hours. Why don't we know? Well, there just weren't enough of them. The study was done in 2016 to 18, and the delays weren't sufficiently bad to have a decent data sample of people waiting beyond 12 hours in an emergency. There are, sadly, a lot of them now. So applying this approach gives you around 500 additional deaths arising from those delays in December. As I say, many of those deaths will happen in January rather than in December, and that's 500 a week. I should be clear from those, which is where the headlines can come from.
Stuart, we've had a couple of questions
of course
about this. One is from Andrew, actually two are from Andrew. Andrew Stalker, do you want to sort of unmute yourself, Andrew, and ask those questions directly?
Yeah, sure. It was just that obviously there's this big talk about the difficulties the NHS is having, but excess death spikes are being seen all around the developed world. So clearly there are other things going on. Obviously, it'd be interesting to see how much this spike would come down, or an average. But I think it's probably unfair just to point at the NHS in this regard.
I don't think I am pointing just at the NHS. We just went through a slide of 8 causes, and now we're looking at one of them in a bit more detail. I think
sorry, go back to that. Many of them are NHS related. Waiting times, BHF research, NHS sick with COVID. So most of them, in fact.
Yeah, okay. That, I mean, that's a fair observation. There's a number of them are related to pressures within the health system, and that's, but I guess I'm not trying to point at the NHS specifically. I'm talking about the NHS because we're talking about the UK. Health services around the world are struggling. Different countries resource their health services differently. So some will build in more spare capacity, some redundancy into the system. Others, like prefer to sort of have almost a just enough kind of philosophy and don't have much in the way of spare capacity. So yeah, health systems around the world will be struggling. There is stuff going on beyond demand pressures. So as we've talked about, elevated cardiovascular risks following COVID, is really a strong effect. The flu season that we saw, all of these are really relevant and all playing into the NHS. So it depends on whether you're looking at the spike, which I think is very, very well explained by the flu season and the really acute delays that we saw, or whether we're talking about the broader excess that we saw through the second half of 2022, where I would be more inclined to agree that there is more going on beyond those demand pressures.
There's a question from John Spain asking whether you can track the A&E waiting times to particular areas.
Yeah, I mean that's so I haven't done that, but you could do that. It would be possible to go regional. In fact, I have done it for a couple of examples. So I was asked to do a piece for the Southwest. So yeah, you can get the data, but it would be an interesting study to do to look at the local associations. We don't have great local data on excess deaths. But it would be an interesting study to do to compare death rates by kind of smaller local areas with what's going on in terms of the delays in those areas. I think it would add more weight to the argument.
And there's quite a complicated question from Adam Jones. Do you want to ask that question yourself, Adam?
Yeah, of course. Hi, Stuart. Adam Jones here.
Hi, Adam.
Hi. Yeah, just you mentioned the recent improvement in ambulance wait times. And just wondering, given Rishi Sunak's kind of commitment to improve that, how much reliability and accuracy we should put on those numbers coming down, and potentially are the NHS going to be too focused on achieving that target rather than the best outcomes for the actual people?
Yeah, I mean, interesting question, isn't it? That when you once you make something a target, the relationship that you're trying to address with that target can often break down. I can't remember whose rule that is. I'm sure somebody will put it in the chat. I don't know. I think with a lot of these things, you can only rely on a triangulation between what you see in the published data and what you hear in terms of anecdata from clinicians. And one thing that's been advantageous about me having a little bit of a platform and putting lots of data out into the public domain is I get a lot of feedback publicly and privately from clinicians, which is really, really helpful to triangulate what I see with a sort of top-down view with what they're seeing bottom up. The situation has improved on the ground. Waiting times are far, far better than they were. That's clear from looking at the January stats. We're going to see a further improvement, I believe, in the February stats. I take your point in theory, but I don't think this is about manipulating statistics.
And there's a question from Peter Cameron Brown saying, how many more weeks do you expect these 500 excess deaths to persist?
So I think I hope it's largely played out. The January statistics were better than December, and hopefully February will be better still. I should be clear that these are the calculation I did, at least, are additional deaths over a sort of utopia where nobody has a very, very long delay. Everybody gets treated in 4 years, so within 4 hours. The number won't fall to zero. you're always going to get some long delays, but we'll be back into the position, temporarily at least, that we were, at earlier stages in the pandemic and in the pre-pandemic years fairly soon. There's a political discussion about whether that was acceptable or not. It was already considerably worse than a decade earlier. But we won't be experiencing the sort of unprecedented shock that we've been through over the last 8 weeks.
You've got, I think we'll get you back on your normal slow now because we've covered the questions that come in on chat. Unless there are any other questions, don't see any hands. So
great.
Yeah.
We're nearly at the end of the slides. I just wanted to dive a bit deeper into some of the other causes. So one of them is about diagnoses. I find these charts really quite shocking in terms of making clear the extent to which the pandemic has had impacts on healthcare. Obviously, we took steps to encourage people to stay at home to prevent the worst of the COVID deaths, but there were no easy options available to us, and unfortunately, there were expected and it's turned out in practice long-term consequences arising. So the one on the left is showing you a fall in diagnoses of diabetes. Now, we know that actual incidence of diabetes has not fallen, could not fall in that kind of way. In fact, there's some adverse interactions, my clinical colleagues tell me, between COVID and diabetes. So more likely to get a diabetes diagnosis after a COVID infection. But you can see just how suddenly it fell. So, that's people staying away from the health system. And that is going to have a long-term consequence where we have a cohort of people who are unmedicated or who are getting onto the appropriate medication later. That's again from my LCP colleague, Johnny Pearson-Studdard. The chart on the right is from the British Heart Foundation. I'm citing there the preprint because we've been working with this for about a year, but this has now been published by the British Heart Foundation fairly recently, showing you about 500,000 people failed to get a new prescription for blood pressure medication in that kind of early phase of the pandemic. So this chart is showing you blood pressure meds, it's showing you statins, it's showing you diabetes medication. So in all these cases, we've just got a really large people who, for one reason or another, whether it was turning up in A&E, whether it's going to see their GP, would ordinarily have been expected to get a new diagnosis of elevated blood pressure or raised cholesterol and get put onto a preventative medication, a statin or a blood pressure lowering med. That hasn't happened and that hasn't been caught up. So that is going to lead to more heart attacks and strokes. It's just an unavoidable consequence of the really difficult choices that we needed to make. That's playing out now. So to the question earlier about non-NHS, it's healthcare derived, but it's not about our sort of urgent care. It's about a failure of prevention. And then as we move out from this into the sort of medium to longer term, I should say, by the way, that there's a similar chart. I haven't shown it because I don't want to be too repetitive, but there's a similar chart for cancer. Haven't shown it because cancer's not yet having driving the excess deaths, as we saw earlier. Unfortunately, I think that pain is still to come. There's a lot of people that should have got a cancer diagnosis that are going to get detected at a later stage, and their outcomes are going to be less good as a result of it. But contrary to what some people were saying early in the pandemic, you don't suddenly get a spike of people dying of cancer because they didn't get their sort of stage 1 tumor identified. Unfortunately, this is pain that plays out over several years, maybe a decade. And then waiting lists. So while you might think of this as more of a health and morbidity concern, actually NHS waiting lists are going to play out and have an impact over the medium to long term. So even something as innocuous as waiting for a hip replacement, that increases people's time spent in pain, which can lead to other adverse outcomes, inflammation. They'll have more sedentary behaviour. They won't be moving around as much. Mental health issues, more likely to get a fall and complications of arising from that. And this is from the LCP waiting list tracker, and it's just showing you, as you can see, this sort of constant increase in waiting lists that's occurred since the start of the pandemic. Things we already had kind of several million people on waiting lists, but that's now up above 7 million with the latest data. So we've talked a lot, and I'm sorry it's morbid subject for Valentine's Day, but talked a lot about all these headwinds essentially on life expectancy. I'll just talk really briefly about how the CMI is thinking about this in closing. So the CMI is the part of the actuarial profession that's responsible for life expectancy modelling. So the CMI would say that we don't provide mortality advice, but we do provide tools with which actuaries can formulate or express their advice. So the CMI is going to place some weight on 2022 mortality experience. So a lot of the things that seem to be going on in 2022 are not driven by short, sharp, not to be repeated COVID spikes. They are sort of constant, chronic, repeated waves of Omicron causing low-level, constant excess deaths. They are health service pressures. They are people who've missed out on diagnoses. They are long-term economic consequences of the pandemic and all the other things that have played into that in recent years. So CMI is going to make some allowance, going to put 25% weight on 2022. Shouldn't worry overly about what that number is. It's not linear. You know, that has about half the impact as if we'd given full weight to 2022. But what that's essentially going to do is it's going to make more allowance for the higher mortality that we've seen, and it's going to result in projecting less optimistic improvements in life expectancy into the future. And that will reduce cohort life expectancies, and cohort life expectancies, that's the projections that we all use when we're thinking about the cost of paying a pension to somebody. So that's going to come down by around 6 months as a result of two changes. One is this allowance for COVID, and the other is a somewhat more technical change. And I won't go into too much detail, but the ONS are going to update their population estimates. So we have got fewer old people than we thought we had in the country. And as some of you will know, when we calculate death rates, we take the actual number of deaths that are observed. We've got really good, solid data on that, and we divide it by the number of people we think we've got in the country based on census and so on. So if you haven't got as many old people as you thought you had, but your deaths are still correct, then it means that your death rates are actually higher and your historic mortality improvements have been lower than you thought. So by correcting for that, that also has an impact. So both of these things are going to bring down life expectancies when the model comes out in June. I'll stop there and just leave a couple of minutes for any last questions. Thanks for all the engagement as we've gone along.
One great question that come in from Bob Compton, which is, have you got any explanation why youngsters are having so many excess deaths, the 20 to 44 age group?
Yeah, that is a key question to which we as a group don't yet have an adequate answer. So there is ongoing work, I understand, to examine this question. CMI has contributed analysis. Some of the causes that we've talked about, let's first and foremost say that this is a small number. So it's a big percentage increase, but it's a big percentage increase in the age group where not very many people die, thankfully. So That does mean that things like mental health can play in. If there's any increase in accidents, suicides, and so on, that could be relevant, and that is very much the case in US data, where there is some good granular analysis, and there's a lot of these deaths of despair playing out. So and we do see elevated deaths from things like liver. So that's that's another one of the causes that's quite elevated, which is obviously associated with alcohol. It may well be that some of it's deaths of despair. It may well be that some of it's undiagnosed cardiovascular issues. So where because that, as you get towards the upper end of that age group, people in their late 30s and 40s, you do start to see the onset of cardiovascular issues. And this is the group that would normally be prioritized for medical treatment. So when the health system's blocked up, the people who would normally skip straight to the front of the queue aren't able to. So all these things playing a role, but I'd like to have better data and a better, more solid explanation, and I hope we will get there this year.
Thank you very much. Eve has asked right at the beginning whether or not these slides will be shareable. Are you able to share these with me, and I can put them on SlideShare and share them?
Yes, there's nothing confidential here.
Okay, so that's a good answer. One of the great metrics we use for the success of a presentation is stickability, and you have got not one dropout. You've had not one dropout throughout this presentation, a gradual increase in numbers, which suggests to me that you held our attention very well. Certainly held mine, and I hope that everyone else will agree with me that that was really, really interesting. And a question coming in: can I share a copy of this webinar with my trustees? Presuming the answer to that question is yes. Yeah.
Yes, I think you've recorded it, right? And happy for it to be shared.
Margaret, you got your hand up. Do you want to ask a question, Margaret? Or Margaret had her hand up, but maybe she's put it down now. I don't know.
Fans of hands. Fans of never die.
Lots of clapping. Lots of clapping though. But,
okay, it's clapping. Right. Okay.
Yeah,
well,
there we go. Yeah. So
we've got to the end of our brief hour. Yeah, and it's flown by. So thank you very, very much, Stuart. And I can see lots of consent around from everybody. Steve, do you want to sort of just finish off telling us what's going on in the weeks to come?
Yeah, sure. Thank you very much, Stuart. I really appreciate your presentation. And as Henry says, big applause from everybody, I think, on that session. It just absolutely shot past. So it's a very, very important subject, and it was very, very informative. So thanks for your input, and delighted that we can share that with Pension Playpen members. Next week, we have the wonderful Margaret Snowden, talking about scamming and updating us on scamming. Many of you will be aware that there's a lot of movement with Dashboard coming along, that scamming is on the rise and continues to be on the rise. So what's Margaret and her team and what are the regulator doing about scamming? And I know Quiet Room and Money Alive are doing some fantastic videos to try and help schemes, trustees, whether it's DB, DC or Master Trust, cope with anti-scamming. So next session will be on scamming, and anti-scamming. So really, really appreciate that. Thanks to everyone today, especially Stuart and Henry, for a fantastic session. If you are not a member of Playpen, please join. If you are a member of Playpen, please send on the Invite Friends tab invitations to all your friends to say Playpen is here. And we think, as an example today, Stuart, especially, we do some great content. So really, really appreciate everybody's input. And as usual, we wish everybody a really good rest of the day, and we pray for peace in the East. So let's enjoy the rest of your day. Hope lots of you will be going out for lots of lovely chocolate and romantic meals tonight, and got all your flowers and cards ready or done. So good luck with that. That's all I can say. So, but appreciate your time, Stuart.
It could be carnage.
Could be carnage. Yes, Charles. Thank you.
Okay.
Right.
So there we go. Anyway, there we go. Thanks for your time, everyone, and enjoy the rest of your day. Cheers, Stuart. Thanks.
Thank you.
Thank
you very much, Stuart.
Bye. Bye.